Hello, dear colleagues. My name is Andrejs Ērglis, and I'm really happy to be in a conference in Ukraine Atherosclerosis, which organized by Ukrainian Atherosclerosis Society, and it is really, in reality, in our hearts and beating together with yours, and Latvia, thanks to God, now is a part of Europe Union, and we really hope to see also you there. And I really understand that Ukrainian and European citizens and Ukrainian citizens' hearts beat together, and that's why I guess it is a really nice name and title of this conference, uniting hearts. And my topic today is to talk about, and maybe it is, there will be a couple points on pathogenesis and also what we are having today. And the title is Imaging of Calcified Lesions, and CCTA and calcium score versus invasive angiography versus IVUS and versus OCT. And sometimes it is maybe a bit wrong story because those are not competing methods. It's very usually those are complementary methods. They're never denying we should understand this, and then maybe there will be slides which helps us, or it's coming from literature, also from my experience, and this is my disclosure statement. And what I really wanted to again to say, and maybe to show what is our meantime understanding about atherosclerosis. And this is interesting how it's changing during the years. I'd say I just talked with one of the authors of modern atherosclerosis theory together with Dr. Glago from United States, and it is Chris Zarins and Christoph Zarins in Latvia, and he's a Latvian surgeon who works in Chicago at that time. Then Glago present his first topic of real modern atherosclerosis theory. And you see that's also now it's changing every day. And why it's changing? Because our, first of all, basic science is improving, and also we can really to evaluate much more. And if you see here, and also in left side and in the right table, you see that coronary artery calcification accompanies the development of advanced atherosclerosis. And it predicts future cardiac events independently of concomitant cardiovascular risk. And this is so important because everyone's know about this, and hope so that we know from GPs to cardiologists and neurologists and endocrinologists, we know about cardiovascular risks, but also it is very important to analyze what is inside in our arteries. And for this reason, again, I will not to go in each point, otherwise it is too long and it's lack of the time. But the end of the day, what we see that calcified nodules are so to occur from the rupture of these calcified sheets. And why I'm talking about that, it is important because if you look on guidelines for management of chronic coronary syndromes, then you see how actually big role playing in meantime calcium, which we can detect by a different kind of examination, and then from angio, and then from CC angio, coronary computer coronary angiogram, and other things. And that's why we are looking on Agatston score, which shows us coronary artery calcium score or calcium score, or we can maybe a bit shorter title. And as you see, if calcium score is higher, also the actually event rate will be much more higher. For this reason, we really need to detect this. And here you also see how from very low to low, then moderate, high, and very high risk. And this is actually what we can really to detect by different, as I said before, tools. And actually, in this is one of the examples, and I guess it's really important to see that it's not only theory, but it's really we see in for our patients, this is asymptomatic, and this is important because this is asymptomatic 79 years old female. And again, too long, but we have a very nice study with our peripheral artery, actually for vascular surgeons and about peripheral artery disease patients. And as you see, the total calcium score, actually it's 4,000. Of course, it is something huge, and it is, but another hand, it is our daily patients. And if you look here, then you see that with every age, we have actually, we have some level of calcium score where we understand that it is a much more, I mean, risky than the lower calcium score. And in this particular case, of course, the lady, she's 79 years old. She has a very, very high calcium score. It's not it's not new study, it is quite old study, but it's very interesting. This MESA study, multi-ethnic study of atherosclerosis, coronary calcium as a predictor of coronary artery events. And that time this is just discussions and first discussions, and then you see it's also, and as I said, this is actually asymptomatic patients. And if you look here, then you see that if calcium score is more than 300, that means that actually cumulative incidence of major coronary events or MACE rate is much more higher and significantly, as you see, statistically significantly higher than if you have even from 1 to 100 or 100 to 300. That's why, again, this is one of the first, I'd say, signals which show you some cut points. Of course, the cut points are changing and everything changing, but this is a very interesting to see that even 20, bit less, but years after, we see how it works. And also we see from much more recent studies like in the Hollenberg and others, and but it's a bit different story. There's around 700 symptomatic patients with suspected coronary artery disease. And as you see, the patients underwent serial coronary computed tomography, and tomographic angiography performed 3.4 to 4 years apart, and atherosclerotic plaque was quantified, including by compositional subgroup, and obstructive coronary artery disease was defined as more than or equal as 50% of stenosis. And then you see how it is again, you see how actually in subgroups changing this calcium score. And again, and also very interesting to see if you look on this and during the years, if you look on right table, you see the non-calcified and even calcified plaque progression and serial changes, actually serial changes for the same patients in calcium score by the baseline score. That is again we see that it is a real evolution of calcification, and this is important to know because sometimes we are looking and then we should predict what will happen with our patients in 1, 2, or 5 years, and then we can to take decision together with patients. Of course, first of all, to change all risk factors, medicine, and so on, but also about the vascularization and other things. If you go back, and this is the same female, and as you see, then we did this is what we started, and actually the Riga was who really confirmed this hard flow, this fractional flow results, computational fractional flow reserve. This is the patient, the study patient. As you see, we did CT scan and measure this fractional flow, CT fractional flow reserve, and here you see how it looks like calcium in coronaries and by CT scan. This is in reality, this is invasive coronary angiogram, and here you see a real real calcium here in proximal part in right corner, and of course also in circ. And even if you look on just with no contrast media, you see a real severe calcium even by X-ray. The problem is, and this is of course again, this is not so simple, because sometimes what you see in angio and in X-ray, this is superficial calcium, not always correlate with in intravascular, intraarterial calcium. No, why it is important? It is also very important, and this lecture also was given and gave for CT guys, and I mean for invasive guys and CTO guys. But why it is important? Because if you see like patients like this, you can again to predict what you can do, but you also should can calculate efforts, what you must do for to fix one or other lesion. This is like how it is fixed. It's fixed with different kind of atheroma changing or calcium changing devices, and of course finished with stents. And as you see, there is a practically full vascularization. And why again it is important? Because based on calcium, especially for invasive guys, but not only, it's also for cardiologists, for GPs. If we send patient to another procedure, we need to understand, and we should think about also risks, and then you can discuss this. And then one thing which is important, that if you see if his Agathon score is high, then also there could be necessary to use different devices like rotational atherectomy devices, rotational atherectomy, and others. And again, mostly it is maybe more instinct for interventionalists, and this also from this ERPCI group. This is like 4C or for this calcium group, and this is important that if you see something like this in CT scan, you also should understand that there will be necessity to use different kinds and maybe sometimes special patient preparation. I'd say one thing, of course, is meantime CT scan, computed tomography, maybe sometimes because of these blooming artifacts, sometimes we can't really to define and to see what is inside there. But what we are looking for, and this is a next decade, it is for sure, this is photon counting CT scan, and I'd say that there will be again revolution in diagnostics. No doubt that we can also use invasive coronary angiography to see maybe something like calcium, but as you know very well that actually coronary angiography, invasive coronary angiography, this is luminogram, and we very often can't to say what's happening with vessel wall. On the other hand, sometimes some predictors show us that as I said before, with X-ray we can define the calcium. Then it is always a question: what is which tool, which method is better? IVUS, intravascular ultrasound, or optical coherence tomography, IVUS and OCT, and comparison of imaging methods, and then you see the different kind of to compare, and then what we are having, and then as you see that for example tissue penetration, this is a different for calcium, and then for IVUS it is much deeper, and it's not so deep with OCT. On the other hand, if you look on calcium arc, then OCT guys who are usually like this, they are saying that calcium arc you can see better, but sometimes, as I said before, those are, of course, it is a bit a problem about the additional cost. It's no question about that, but actually sometimes we need to use both methods for specifically very challenging cases. And also why it is important, because we can then to predict the intervention success, or maybe even to predict what will happen with stent, and if you put in this unlikely environment. But that's why we need to prepare a vessel for stent implantation, for scaffold implantation. For this reason, there is a very good devices like both IVUS and OCT. Personally, I like, and I'm working more than 30 years in this field. I like intravascular ultrasound specifically because now they have a new programs and so on. But also, of course, if you look on the results, then OCT can show you better, even more specific results. Why it is important? Because IVUS and OCT depends on studies and depends how you look on this based on calcium score, can predict stent under expansion. But you know, the stent under expansion is really predictor of MACE rate in doesn't matter, in 6 months, 1 year, 2 years, and even in 10 years. And this is the second case, and this is also coming from one study which was done in Riga, and actually we do for the last, again, 25 years, so many participating, so many imaging and plaque preparation studies and also medicine studies. But for example, here you see a real calcium, and specifically in bifurcation, which is a quite complex as well. The 76-year-old man that done his intravascular imaging, and for specifically for our understanding, we really use both methods. It's mostly because of research. And then you see calcification 360 degrees, the same you see also by OCT, and also length of this, and then we can analyze, and it's also done. There was a very good job of PhD done by Professor Andrejs, who helps me also to prepare this presentation. But why it is important? Because this is important for understanding what happened with plaque. And it's not, here we can see very well calcium, but also plaque thickness we can see, and even with other tools we can see morphology of plaque, like VH and VH virtual histology or IMAP. And for example, if you look again, it is done by Professor Riga in this PhD thesis, and then it is very interesting to see what is the more sensitive or specific method to use. But I'd say that all those methods which we used inside, actually instead to intracoronary angio, show us much more better what is the environment inside and what we treat. And it's not always calcium. We also can look on soft plaques and others. This is actually bit to continue research and mostly about volume, about plaque volumes, about calcium volumes, with different with OCT, IVUS, and IMAP and VH, and then you can see. But again, I mean, in future there will be even better and more precise softs, I'd say. So it's treated, as I said, because we know the real dimensions. Because we know the real dimensions, then we can get the real devices. Now we have IVL, which is a ultrasound plaque or calcium. Device which can be used and then to destroy calcium. But in this particular, so it's many years ago, it is just done by a cutting balloon and also scoring balloons, and that time we compared those, and as you see here, also we see what we can get with those devices, and for example, partial fracture or complete fracture. And this is important because if you have a complete calcium fracture, that means that you also can put a stent in very easily manner for and very media to medium principle. No, this is, as I said, things are going further, and now we have IVL, and we have, of course, not talking about rotational atherectomy and other devices, but this is important that we really understand what is inside our arteries or our patient arteries. And with this, as I said, I know more concentrate of calcified plaque modification, but we also can really to look on how medicine works on different kind of structures inside the plaque. This is done. This is a final touch and final imaging after this complex lesion treatment, and as you see, result is very good. And after 3-5 years, still patient was alive, and there's no compliance. And this is I will finish with my really favorite Leonardo da Vinci picture, Gioconda, and you see the detail, and the detail is usually people talking about eyes, but it's not the eyes. Eye is also the sum of something. But if you look on details, you should not forget this full picture. For this reason, we are also look on Ukraine, but if we look on Ukraine, we are thinking about whole world, and but this that's why our hearts are beating together. And Slava Ukraini! Thank you very much.